Hey, y'all. Now we are going to talk about, we've pretty much covered all of the drugs that are going to support the immune system. Now we're going to talk about drugs that are going to suppress. We have talked about why we would want to suppress the immune system, right? We want to suppress the immune system if our, excuse me, I forgot what I was going to say. If our histamines are going crazy, we want to suppress those histamines so that we don't have an allergic response. If our inflammatory process is going crazy, we want to suppress that inflammatory process to thereby decrease pain, decrease discomfort in the nasal passages, all of those things. And if we have an autoimmune disease, we want to just suppress the immune system altogether so that it doesn't attack itself, right? So when we're talking about drugs that suppress the immune system, we're going to be talking about antihistamines. And your biggest antihistamines, you have first generation antihistamines such as Benadryl, which we're all familiar with. And we have second generation antihistamines such as Sertrazine, which is your Zyrtec. You have, other things like Loratadine, which is Claritin. Those things we need to recognize as antihistamines. Your first generation antihistamine, Benadryl, is going to make your client more drowsy than your second generation antihistamines, just by, we talk about how things over time and we can change certain properties. That is one of the differences between first generation antihistamines and second generation antihistamine. We use them for allergies, which we know, and prophylactically with things like giving blood or when we're giving new medications, we're going to sometimes use those things to prevent allergic reactions. CNS depression, sedation, dizziness, drowsiness, those are going to be your primary side effects for those medications. And dry mouth. So think about the way that you feel, the way that most people feel when they take Benadryl. And, you'll naturally know those side effects, okay? When we talk about NSAIDs, we've already talked about them. You know what it includes. NSAIDs are non-steroid anti-inflammatories. That's how they're working with the immune system. They're decreasing that inflammatory response. So we know that they're going to treat inflammation and pain and fever like we already are aware. Nasal decongestants. So the way that they are going to work is essentially they are going to decrease the inflammation, but specifically in the nasal passages. So these are going to be things like phenylphenephrine. These are the things that are in like your Dayquil drugs, that phenylphenephrine, and your Sudafed, pseudoephedrine, those products. Any nasal decongestants we do not want to take for longer than 5 days. That is a big teaching point because it causes something called rebound congestion. So your body kind of gets used to it, and then they can't breathe without those drugs. Those nasal passages become reliant on those medications, decreasing those vessels. So we're going to instruct our patients not to take them for longer than 5 days. When we talk about immunosuppressants, new drug category, we're suppressing the immune system not contained to a certain area, not one portion of the immune system. We are suppressing that immune system altogether. When we're using these primarily steroids and things like Sanmune and Gengraph, those kind of things, we are suppressing the immune system. So for these, the side effects are going to be more significant than just rebound tenderness and drowsiness, right? Infection is going to be the biggest thing because we are decreasing that those body's natural defenses. So leukopenia is going to be a biggie with immunosuppressant drugs. Cytopenia is going to be a very big side effect of these drugs. Nephrotoxicity, hyperkalemia, hypertension, diarrhea, and nausea. So as nurses, we need to monitor for those things. And again, when we think autoimmune diseases, your brain needs to go to things such as lupus, rheumatoid arthritis, and organ transplants. When we talk about when do we really not want the body to fight back? We do not want them to attack the patient in the instance of these drugs or in the instance of these disease processes. Glucocorticoids. There are some videos that I need you to watch on glucocorticoids. There are beautiful things about steroids. Everybody feels great when they get a steroid, and then there are some not so good things about steroids. Steroids are meant to be used on the short term when they can. In the instance of disease processes, such as lupus or such as autoimmune diseases, the body is going to require them on a longer time period, but we are going to see some significant side effects of these drugs. Their indicated use is to suppress the immune response and decrease severe inflammation, because again, inflammation is the inflammatory process is a response of the immune system. They cause behavioral changes. So think about when you've gotten a steroid shot, they're sometimes going to make you angry. They're going to make you more reactive. They're going to make you hungry. They're going to make you more on edge, more aggressive at times. In addition to that, they can cause hyperglycemia. That is huge. Our patients who are already diabetics, if they are prescribed glucocorticoids, they're often going to also be placed on insulin for that time period as well, because it's going to shoot up their blood sugar. Also, again, the weight gain and the increased hunger. And then we're suppressing their immune system, so we're increasing their risk for infection. So we've got to be intuitive to look for those signs of infection so that we are aware of, so we can catch them early and we can pay attention to those things, and we can further combat, that likelihood, their increased likelihood for infection. Notice these drugs end with SONE or LONE. So with this test, you have a lot of drugs, but you also have a lot of similar endings. So that's going to help you out a whole lot. Hydrocortisone. So remember I told you we weren't covering chapter 11 a whole lot because you can take hydrocortisone by mouth or you can take it topically for those same responses. Anti-inflammatory creams like diclofenac, you can take orally or they can be used topically. They're working the same way. They're just working locally rather than systemically. So when we talk about all of those things, I want y'all to pay attention to that these drugs, almost all of them, can be given in alternate routes, specifically topical routes. Glucocorticoids, we talked about all of that stuff. All of the drugs that I just told you about are going to suppress the immune system, not support it. They're going to improve the symptoms of the patient who has the disease process, but they are going to do that by suppressing the body's natural immune system, which is what's going to make their side effects very different from other drugs. We need to know the good sides of glucocorticoids. We need to know the bad sides of glucocorticoids. We're going to talk about that again. This is just kind of an overview so that you're familiar with everything and you know what's on your exam. But we're going to recover some of this stuff and just talk about it a little bit more in depth on Monday when we're together. The last let's see, the last really thing that we're going to talk about are your drugs used to treat cancer. There are going to be 8 categories of drugs used to treat cancer, and it's specific to the kind of cancer that your patient has. If your patient has when patients are given a cancer diagnosis, we generally know its origin. We also are going to need to know, there's certain receptors on cancer genes. So like, let's just talk about breast cancer. If the origin is in the breast, it can have certain receptors. It can be estrogen positive. It can react positively to estrogen receptors, or it can, it can be negative, where it's estrogen is not feeding that cancer, right? So we are going to need to know those specific studies so that the oncologist knows what drug regimen is appropriate for those patients. But it is specific to the type of cancer they have, what those cancers, what they respond best to. So while we don't do a culture and sensitivity for patients with cancer, it's the same principle. We know that that cancers that are that feed off of estrogen, that's where they grow. They feed off of estrogen. We're not going to give those patients estrogen whatsoever, right? We want to give them we want them to have no estrogen. We don't want to feed that cancer. Whereas people with prostate cancer, we're gonna give them a different regimen based on what they have. Okay. So anti-metabolites and anti-tumor antibiotics, those are going to be and plant alkaloids, those are going to be your primary cancer drugs that you're thinking about that are going to cause things like alopecia, hair loss. They're going to cause bone marrow suppression. They are just they're killing everything. They're killing good they're suppressing the cancer, the growth of the cancer, but they're also suppressing your other cells is the best way that I can explain those to you. They're going to cause nausea, toxicity, rashes, changes in the lungs, changes in the bones, and also going to cause things like neurotoxicity. So those drugs, we are going to do a lot of checking of white counts, checking, weekly labs to keep up with these patients, teaching of, your hair is going to fall out. What does that mean for you? Let me get you hooked up with the right resources. That nausea and vomiting is going to interfere with their everyday life. We need to, as nurses, pay attention to those things, be mindful of those things, and understand what our role is in both educating and providing support. Plant alkaloids also I already told you that. Yeah, those are going to go into that same category. So anti-metabolites, anti-tumors, and plant alkaloids, those are going to be your drugs that you are getting, you're giving your patient IV. They're going to have implications to be given IV specifically. And they're going to cause those big real deal side effects. They're your chemo drugs. Hormones. We're going to sometimes treat breast cancer with hormones, testicular cancer with hormones, and prostate cancer with hormones. They are going to cause your more hormonal reactions. They're not going to cause alopecia. They're going to cause hot flashes, decreased sex drive, still nausea, vomiting, headache, dizziness, and depression. They're going to be those more, again, hormonal type reactions. If you understand what the drugs are, then you will understand the kinds of reaction that your patient, those side effects that your patient is going to have. Let's see, that next category is biological response modifiers. Those are used for leukemia, malignant melanoma, AIDS-related Kaposi's sarcoma, and hepatitis B and C. They're going to cause anemia, bleeding, and difficulty breathing are the major side effects that they can cause, and they are going to be your interferons, interferon 2A, interferon 2B, again, given IV. Monoclonal antibodies are going to be given for things like colon, lung, head, neck, and breast cancers. They can cause infusion reactions. They are also going to be given intravenously. They can cause problems with renal failure, thrombocytopenia, and malaise. Immunomodulators are given for things like multiple myeloma, headache, fever, nausea, vomiting, and radioactive isotopes are given. They are the iodine seeds that are implanted into your patients for prostate, lung, cervicals, and endometrial cancers. So we're going to revisit all of this stuff on Monday. Make sure y'all have a good understanding, but I wanted y'all to have some recordings for the weekend. Shoot me an email if you have any questions. We're going to go over, actually, let me We're going to go over the additional drugs, primarily pulling drugs out of your book for this chapter. Out of those charts, we will look at the top 200 drugs together and see if any of those need to be pulled out on Monday. But these are going to be your primary drugs that are going to be on this test. Focus heavily on what the drugs are treating and their mechanism of action. And of course, examples of the drugs, as always. Hope you'll have a great weekend, and hopefully these will not take long to post and you will have them to listen to throughout the weekend. Holler at me if you have any questions, and thanks for listening.